All right. So today on Aims on Health, we're honored to have with us Joe McGilvrey from Apex Physical Therapy, local physical therapist down here in Southwest Florida. And today we're going to discuss a little bit about plantar fasciitis chronic plantar fasciitis and some of the things that go along with that. So previously we spoke on one of our other episodes about plantar fasciitis, and we're going to just delve into it a little bit different today. So Mr. McGilvrey, I'd like to give our audience here a little bit of background of where you're from, your business, and how you're dealing with the current pandemic that we're experiencing right now.
Yeah, absolutely. Born and raised in the Chicago area. My wife and I moved down to Southwest Florida 2005. Right away, we opened up Apex. And that was in our Fort Myers location. And then in 2007, we started our Cape Coral location, which we still have the two running locations. And then our practice has kind of evolved. We can make that more of a story, but right now, basically, we have 3 tiers. We have physical therapy, we have diagnostics, and we have athletic performance. So that's kind of our 3-tier bucket, and that's how we're practicing right now. Relating to the pandemic, obviously, as everybody's taken a big, hit initially, you got to kind of adapt to that. We did. Week 1, we started our telehealth. We've never done telehealth before, but we jumped right in, and basically we're able to salvage pretty much all of our clients. So we were doing then about that 70% telehealth, 30% in-house, and now it's kind of trickled back around. Previous to this past week, we were probably 90% in-house, 10% telehealth, but now this week is with a little bit of a spikes in the area. We're kind of getting a little bit more into the telehealth, but we're kind of going for the ride, as we say, and we're number one is our patients and keeping them safe, keeping our employees safe, and so here we are. And I appreciate you having me on the show.
Now we appreciate you reaching out and wanting to be on. Kind of my first guest that requested to be on the show.
Look at that. That's awesome. I love it.
So let's dive right into it. So like I said previously, we spoke about plantar fasciitis, one of the things that we deal with a fair amount in our practice, but there's this other element of plantar fasciitis or heel pain that we see. But first, I just want to get your perspective on plantar fasciitis and some of the unique modalities that you have to treat it, and sort of the things that you try to get your, whether it's your athletes or your weekend warrior types back, quickly to their routine.
Yeah, absolutely. So number one, it really comes down to the imbalance that we find. So there's going to be imbalances of muscles and tendons that are too tight, and then there's other areas that are too weak. And if you can kind of find out where those imbalances are, that's when you can kind of look more long-term. Early on, when we see them, obviously they're in a lot of pain, so you got to kind of deal with that. So we have different modalities in the clinic that we target that. One of them is we call ASTYM, so it's ASTYM. It's basically just creates a stimulus in the body. It's basically tool-assisted therapy. I have them right here, so the tools kind of look like that.
What's your tools?
Yeah. So it's just, and these are plastic, so they're not the metal that you hear of, sometimes Agrestin techniques, there's rock blading. Those are a little bit more aggressive. These are not as much, so you're not going to see any of the bruising effect, and very minimal, if anything, with that. The way that this works is it basically just a general term. It gets in there and it knocks down bad fibrotic scar tissue, and it preserves the good tissue around it. And that's creating then a stimulus of bringing blood flow in, which helps flush the toxins out. And then that stimulus effect will last, they say, up to 24 hours. So in that time, our athletes love it because they can stay active, and we want to promote that activity. So we don't want to shut them down. We want to get them moving, keeping the blood flow going, keeping the stimulus going. And amongst that, we have other modalities. We have a new thing called NeuFit. It's NEUFIT. It's using direct current, which is different than most electrical stimulation devices, which uses alternating current. The direct current actually is going to send a stimulus to the area that we're targeting. That's going to create the brain being involved and create the neuromuscular loop down to where the injury site is. So we almost saying that, and just to our patients, that we're kind of rebooting you. So your brain has put a compensation that there's pain somewhere, and we're kind of reteaching the brain that's saying, okay, yeah, we understand that, but we're in the process of fixing that. So we get that kind of that restriction point off there a lot quicker than if we didn't have this modality in place. So.
All right.
Those are the two heavy hitters, and then a lot of stretching basically is the third thing.
Now, in your opinion, do you focus a lot on the gastrosoleus, or should I say the calf muscle, a lot when you're dealing with this, or the Achilles? Do you go more on Achilles, or do you focus on the plantar fascia? You know, what do you find is most effective?
Actually, you brought up an awesome point, because the biggest missing piece is the soleus muscle. That one is the missing one by almost everybody. So they're all doing the calf stretch because everybody knows the calf stretch. Once they start doing Dr. Google, as we call it, they know about the plantar fascia stretch. Nobody tends to bring in that soleus stretch. And that's, to me, the biggest crucial one that you got to, because all of them come in and are affected, and they affect that heel area. So if you don't, you're missing a big part of the stretching component.
All right. Yes, totally. Now, what about the, I've been interested in the anterior compartment a little bit, the tibialis anterior. Any thoughts on the tibialis anterior or the anterior compartment and the role it plays in plantar fasciitis at all?
Yeah, actually, and it's really cool, because with the A-stem that we use, that's the big key, and that's why we brought it into our practice. The scraping or the tool assisted therapy, we don't just treat the injured site, we treat basically the whole limb. And we find actually a lot in the TA, especially as you get near the bone there, it's actually pretty fibrotic, and we get in there and start working, and we start loosening that area up, and then getting that blood flow. They feel different pretty quick. So again, usually people miss that, but again, you got to treat the whole site. You can't just treat where the pain is.
Correct. So I have to admit, like, a lot of my patients, they get better. They come in with the heel pain, and they want to get better. You know how patients are; they want to be better yesterday.
Yep.
So generally, I give them an injection maybe or so of a steroid. It's not really patients want a result. They want, something tangible. So we try to give them something that gets them better, and we try to break down the process and figure out what else is going on. But I find a majority of them get better, in 2 to 4 weeks with some immobilization and, stretching and things like that they can do on their own. But there are some that, they go, they're a little recalcitrant, as we say, or a little stubborn. Or they come in, 6 months, 12 months, they've been dealing with this off and on, for that period of time. And then we find that there's some other components that attribute to why they're not getting better. One being maybe possibly stress fracture, maybe some internal tears. But another thing that we find is the tarsal tunnel, some nerve entrapment. So from your standpoint, what do you see in those patients that maybe come to you maybe with over 6 months of heel pain that haven't gotten better, with traditional means? What do you find with those patients, and what's been working in your hands?
Well, it's awesome that you brought that up, because that's actually why we have a diagnostics component now, because prior to our diagnostics, we're kind of doing a guessing game. We're not truly knowing. We're kind of trying something to see if it works, and then steering to something else if that doesn't work, back and forth. So diagnostics, for those listening, I'm talking about EMG or nerve conduction studies, electromyography or nerve conduction studies being one, and then the other component is MSKUS or musculoskeletal ultrasound. So those two kind of work, hand in hand. What it comes down to now is we have those people who are more on the long chronic level. There could be something totally else going on. So for us, we want to do a diagnostic scan to see. And these tools or these diagnostic services are going to show us right away. So EMG, NCS, we can see, is it a tarsal tunnel syndrome in fact, and where is the, focal neuropathy at? And we can pinpoint that. or is it possibly, you know, an L5S1 component that we didn't even think about, because that can also be causing heel pain as well. So with the EMG and nerve conduction study, that's going to tell us between those two. And then another thing that, as you probably see too, is you get patients who complain about this heel going on, but sometimes, and even us in our field, we don't look at the other side. So there could be another component. There could be some stages of neuropathy going on too. So we always going to do a comparison study when we're doing the testing, and there could be that going on as well, causing, you know, they're relating to these issues. So that you'll change the component of the feet, you know, the feet will start caving when you get that, you know, neuropathy going on. So
That's a great point. The neuropathy component is a whole nother can of worms that we can delve into. But for right now, we're just going to stay on the on sort of the nerve entrapment, or more of a internal component. So first, I'd like to congratulate you on you. So you passed your certification exam.
oh, yeah,
that's a big deal. So, you know, for
thank
us,
you.
it's hard to find somebody who can adequately do NCVs and EMGs for us, because that's a when we get to that point where possibly therapy hasn't really helped, or we could pinpoint the issue where surgery may be more of an option. It's imperative that we know sort of where that entrapment is occurring, and that's big. So can you maybe maybe go into a little bit of how that you know, how you're going to utilize that in your practice, and how you think it's going to improve your patient outcomes?
Mm-hmm. Absolutely. So our company in itself, we do a lot of focus on community-based marketing. So we kind of go to the community, we bring them in, and then when we find things, so let's say we find like a tarsal tunnel syndrome, we're going to seek out to where, you know, we need a good, you know, podiatry group to send to say, you know, what we can only do so much for it, but we need you to look in and delve deeper. Maybe a surgical release is the only thing that can be done at that point. So that's what we kind of, you know, so for us, we have to be spot on almost, you know, getting to a good diagnosis. So we can't officially diagnose them based off the EMG test or the NCS, but we can point in the right direction. We can rule out a lot of other things. So, you know, for us, you know, if I get this person with this heel pain, and I mean, when I'm doing the NCS testing, first of all, I'm looking at the sensory nerves. So the sensory nerves, even though they're very difficult to get, if I find one on one side and I go to the other, you know, the other side and it's different, then I know that there's something going on. Then I go to the motor nerve. So motor nerves, what I'm looking for, two things. Is it a demyelination issue, which is less of an involvement, or is it an axonal issue, which is going to be more severe? Then if it's axonal, we're sending right off. You know, we need to see what's going on. Is if there's a focal, you know, neuropathy going on, if we don't get it treated in a certain time frame, that might not ever come back. So that's where, you know, then we reach out to, you know, our providers and say, hey, you know, we have this patient confirmed axonal, you know, we need to get this looked at, you know, by someone, you know, who can possibly do a surgical procedure to fix. So, or you know, what, you know, maybe injections or whatnot. So,
Right. So, I mean, I think, you know, those are great points, because I think from my standpoint, once you start getting into the more complex patients that have been having, you know, resistant to care, is good to kind of be able to pinpoint where exactly we're trying to work. And a lot of it could be done, like you said, a lot of this could be done clinically, but it does help a little. It does help, you know, a lot to be able to have that the nerve conduction studies or the EMG that help kind of allow us to give a little more insight on what we're working with. So so that's great. So so explain a little bit to me about your I know you mentioned earlier about the telehealth. Explain like how physical therapy and telehealth kind of goes, how that's been working out for you, you know, briefly.
yeah, absolutely. So basically, I mean, we set up just like we're doing right now. We set up a Zoom meeting. We send the patient their link, they get on. And basically what we're doing is we're not just looking at the patient, but we're looking at their environment. So that's the one cool thing that we found now is people always do harm in their own environment, but when we can now see their environment. So we can say, is that the couch that you always sit on? Is that the stairs that whatever it is, we look at beyond the patient, and then we have them go through their little environment to see, where if we can pick up bad habits. And that's the big key. And then for us, obviously, we see their movement patterns. We do exercises with them. We can demonstrate back and forth. We can show what they need to do. They reproduce. We can send them then links after to, this is going to be your exercise until we talk again. So again, it's obviously missing the hands-on component, but it's bringing a different component as we can look into their actual environment. And we've actually had people bring their phones, just like I'm on right now, to the gym and say, you always tell us about these lifts. Show us the lifts. Put the phone on the ground. Let's look. So it brings out something totally different. So the telehealth's not going to go away. When COVID goes away, it just gives us another little bucket, another way to reach out and see patients. So.
All right, that sounds good. Now I guess now we're going to head over to the part of the program in which I'm going to ask you a series of hard-hitting questions. And you can't get out of any of these answers.
Yeah.
It's not allowed. All right.
Gotcha.
So it's the first one. I saw that you went to. We saw that you went to Indiana University. So I have to ask you, what the heck is a Hoosier? You got to break that
down. Okay, so I'm gonna go to the story that sticks most in our area, and I'm from Illinois, so I'm not from. I just went to school there, but the theory is if you get down into the southern parts of Indiana, and it's like back in the day when people go door to door salesmen, when somebody would knock on the door, they go, "Who's there?" That's how it kind of started.
My research department didn't get me that. That's the today I learned moment right there. All right. That was a good one. Yeah. So you went to Indiana once again, and you're from Chicago.
Yep.
So Notre Dame or IU, which one? How come you didn't go to Notre Dame? I know a lot of Chicago people go to Notre Dame. How'd you end up at IU?
Well, Notre Dame actually is the school I followed as a kid, So Ishmael, oh my gosh, he was like the man back in the day. So right. Notre Dame, I'm always partial to. Indiana is great on basketball. That's about, all. To be honest, Indiana was a better fit for me to get into PT school. I don't even know if at the time in Notre Dame had an actual PT program, but I know Indiana had a reputable one in the state. So that's why I went there.
Yeah, it kind of threw me off. I didn't know you were from Chicago, so I got to ask you a Chicago question.
Absolutely.
Cubs or White Sox?
What, Cubs or White Sox?
Yeah, Cubs or White Sox.
My family split directly in half. I'm partial. I'm a White Sox fan, but I'm not the hater of the other team. So there's times where you can't stand the other team. That doesn't work.
Those answers.
I'm White. I'm White Sox. I'm White Sox.
White Sox. There you go.
Outsider.
Pick a side. Pick a side, Joe.
Outsider.
All right. So I thought you were for some reason, I thought you were from Indiana. So I was going to ask you, who is, in terms of the greatest quarterback of all time, is it Peyton Manning or Tom Brady? So now, yeah, I told you guys questions, man. You can't.
It's Peyton Manning for me, man. Right. Yeah. I can't, Boston Reds. I'm not gonna even go there because I'll go there. Boston Red Sox, no, and New England Patriots, no.
All right. You can say it again. We could have you back on as many times as you want. You're
awesome.
Good money with me.
All right. Good.
So then, I guess the final question we're gonna do right now is CrossFit or HIIT.
For me personally.
Yes.
CrossFit.
Oh, you CrossFit guy.
All right. Yeah. It's the reason why is I can't master it. It's tough, and it breaks me down every time. So I always like that being broken down. I'm gonna improve from that. HIIT, I can kind of get through. You can kind of gauge your own, this is what you got to do. CrossFit, man, breaks me down. So that's why I'm going CrossFit.
All
I
right.
do them both though. So.
All right. And then I guess one final question, since you're from Chicago, I got to ask you one other Chicago-based question. You got LeBron or you got Michael Jordan?
Oh, Michael Jordan all day long. All day long.
That was a layup there. I set you up with that. I'm not
Yeah,
even,
you threw us. You
that's a
told
whole
me what
nother,
pitch was coming.
that's another episode. I'm gonna let you go on that because you're from Chicago, so I expected that. So
Awesome.
I'll say it. So all right, Joe. So it was a pleasure having you on here today. Try to just get the meat of the matter. I have a couple patients that have gone to Apex and with results, a lot of post-op stuff mainly, and I've been sending a couple nerve issues over. So excited to have that build on that relationship. So any last things you like to add before we sign off today?
No, I just appreciate you so much having me on and talking. It's a great talk. I loved it. And really knowing what I know now, me being board certified in ECS, the electrophysiology, I just want more and more physicians to look and say, what else could it be? Knowing that we can rule so much out and make it just, laser focused for you to do what you do then. So that's what we've seen in the 2 years that I've been in my residency program with this. And that's where I'm going with it, from here on out. So. All right. Laser focused on treatments. That's what we want.
All right. That's great. All right, Joe, once again, it was a pleasure having you on, and hopefully we can do this again, sometime soon. And,
Absolutely.
Today, for Aims on Health, we had, Mr. Joe McGilvrey, sorry.
Yep. Perfect.
From Apex Physical Therapy. And, if there's any, he's a great therapist in the area. And once again, we're trying to give the information to our audience on what's occurring and how we can better treat and help them with their foot and ankle issues. So signing off, Dr. Cumberbatch with Joe McGilvrey. Have a great day.